Imagine a major city that has just been hit by a devastating earthquake.
Right, like total destruction everywhere.
Yeah, exactly. The roads are cracked, the bridges are swaying. I mean, the entire infrastructure is just fundamentally compromised.
And in any normal situation, your first instinct is to send in the repair crews immediately.
Right. You'd dispatch the foreman, you'd start pouring concrete, and you'd just get to work rebuilding the city.
It's the standard biological response to trauma, really. It's an immediate, all-hands-on-deck emergency repair protocol.
But what if, instead of fixing those roads, the mayor of the city issues, like, a completely radical order?
Oh, this is where it gets interesting.
Right. Every single truck, every piece of steel, and every available worker is suddenly diverted. They're ordered to build a massive, urgent food pipeline leading out of the city instead.
So the cracked roads and the swaying bridges, they just have to wait.
Exactly. They are completely ignored, and that tension, that biological triage, is exactly what we are unpacking today. Welcome, everyone.
Glad to be here.
Today, our mission is to explore the incredibly complex relationship between breastfeeding and the body's ability to heal and rejuvenate.
And we really wanted to get to the bottom of this. We've pulled together a massive stack of sources for this deep dive.
Oh, yeah, we went deep. We've got medical blogs, lactation databases like the Infant Risk Center, clinical guidelines from NICE, and even actual aesthetic clinic protocols.
We're looking closely at how lactation alters the body on a cellular level, finding out exactly which treatments are safe and effective when you're nursing.
Right, everything from like collagen supplements and med spa facials to hormone therapy and vaginal lasers.
Because there is a lot of conflicting information out there.
There really is.
Yeah.
So whether you are a new parent currently navigating the postpartum period, or maybe a medical professional, or just an insanely curious learner, this deep dive is for you.
We're going to reveal that fascinating, hidden biological tug-of-war between feeding an infant and repairing a mother's own body.
Okay, so let's unpack this. Going back to our city analogy, we know the mayor who is diverting all the resources is basically a sudden shift in hormones.
Right, a massive shift.
But how exactly does this hormonal shift put the brakes on wound healing? I mean, what is actually happening there?
Well, it all comes down to the mechanics of milk production. When a baby is born, the hormones prolactin and oxytocin just surge to unprecedented levels.
And prolactin is the one that triggers the body to actually manufacture the breast milk, right?
Exactly. Prolactin makes the milk, and oxytocin allows for the milk ejection, which you've probably heard called the letdown reflex.
Okay, making and moving the milk. Got it.
But here is the catch. To keep that milk production line running, prolactin actively suppresses the ovarian production of two other crucial hormones, estrogen and progesterone.
Wait, it just shuts them down? I get that the body prioritizes the baby, but from an evolutionary standpoint, wouldn't a wounded mother be a massive risk to the baby's survival?
You would think so, yeah.
So why shut down tissue repair so completely just to make milk? It seems counterintuitive.
It's really about the sheer energy economics of the human body. I mean, producing breast milk burns anywhere from 500 to 700 calories a day.
Wow. That is a massive daily toll.
It is. The body simply cannot fund two massive energy-intensive projects at the exact same time.
Ah, I see. So it can't sustain the caloric demand of feeding an infant while simultaneously funding like a major structural rebuild of the pelvic floor.
Or healing a deep abdominal incision from a C-section, right? By suppressing estrogen, the body essentially forces a temporary pause on maternal repair just to conserve energy.
Which brings us to this medical term the sources keep highlighting, genitourinary syndrome of lactation, or GSL.
It sounds super intense, doesn't it?
It sounds terrifying, honestly. And according to the literature, it fundamentally alters the postpartum landscape.
Yeah, so GSL describes the hypoestrogenic state that lactating mothers enter. Hypoestrogenic just means severely low estrogen.
Right.
And biologically speaking, this environment heavily mimics menopause.
Which is wild to think about happening in your 20s or 30s. But going back to our earthquake analogy, estrogen is basically the foreman of the construction crew, right?
That is the perfect way to look at it. Estrogen is the master regulator of tissue repair.
And I think a lot of people, myself included, just mentally box estrogen into the reproductive cycle category. Like, it's just for making babies.
Oh, its job description is so much more massive than that.
Yeah, reading through these clinical protocols was eye-opening. It promotes collagen production, it regulates inflammation by shifting macrophages into a pro-repair state.
And macrophages are those white blood cells that clear out debris, by the way.
Right. Right, and it even drives angiogenesis, which is the creation of new blood vessels to heal wounds.
So if we connect this to the bigger picture,
Hmm.
without that foreman on site, the body struggles immensely to heal from the physical trauma of childbirth.
Because there's no one directing the workers.
Exactly. Because of this low estrogen state, vaginal tissues become incredibly thin and fragile. Dryness is a severe issue.
And even the skin's elasticity just plummets, right? Making stretch marks way more prominent.
Yes, the very hormones keeping the baby fed are intentionally keeping the mother's cellular repair on standby.
So if you are listening to this right now and wondering why a C-section scar is still aching or feels incredibly tight at, say, 4 months postpartum, this low estrogen biological triage is exactly why.
It's doing exactly what it's supposed to do, even though it's frustrating.
Which really begs the central question of our deep dive today. Can treatment while breastfeeding affect or even restart this stalled healing process without jeopardizing the baby?
That is the million-dollar question.
Because if the body is starving itself of collagen and estrogen, why can't a mother just eat her way out of the deficit?
Well, looking at systemic solutions like supplements is definitely the logical next step, and the most prominent one in our research is absolutely collagen.
Okay, wait, let me push back on the supplement industry for a second here.
Go for it.
If collagen is just a structural protein, isn't taking some fancy supplement essentially the same as eating a highly priced chicken breast or a steak?
A lot of people wonder that.
Right. I mean, how does a scoop of powder actually know to travel directly to the skin and the joints? Is this just incredibly clever marketing?
It's a fair question. The distinction here lies in a biochemical process called hydrolysis.
Hydrolysis, okay.
The supplements highlighted in the efficacy research, specifically hydrolyzed marine collagen, have been pre-processed.
Meaning what exactly?
Well, when you eat a chicken breast, your stomach has to do a tremendous amount of heavy lifting to break those really complex protein structures down.
Right, regular digestion.
But hydrolyzed collagen has already been broken down into very small peptides and specific amino acids,
Okay.
particularly glycine and proline.
Ah, I see. So it bypasses the heavy lifting of the digestive tract and enters the bloodstream much faster.
Precisely. These specific peptides are highly bioavailable. The body recognizes them not just as generic caloric fuel, but as the direct biological building blocks required for tissue repair.
And regarding the safety profile for lactating mothers, the sources say it is considered highly safe.
Yes, these amino acids support the mother's structural needs without passing any harmful compounds through the breast milk to the infant.
Though I should point out, the lactation databases are very clear about one thing. It is not a magic milk booster.
Not at all. There's zero clinical evidence that collagen increases milk supply.
So the benefits are strictly maternal. It aids in repairing pelvic floor connective tissues. It supports the tensile strength of healing C-section scars. And crucially, it provides the amino acids necessary for keratin production.
Which is a huge deal for postpartum women.
Yeah, keratin is often used to combat the massive postpartum hair shed that typically strikes around, 3 to 6 months after birth?
Exactly. It's a very common time for that to happen.
But there is a massive red flag in the sources about supplements that we absolutely have to mention to you guys.
Yeah, the regulation issue.
Right. Dietary supplements are not regulated by the FDA in the same way prescription medications are. A label can say pure collagen and still be hiding a lot of unwanted extras.
Unfortunately, lower quality supplement brands frequently test positive for heavy metals like lead, or they have unlisted chemical additives.
Which is terrifying if you are nursing.
It really is. So for anyone lactating, the sources strongly recommend looking for an informed choice certification on the label.
Or finding a brand that publishes its third-party testing results just to guarantee purity.
Yes, third-party testing is non-negotiable.
Okay, so high-quality third-party tested collagen is a green light. But what about replacing the actual foreman?
You mean the estrogen?
Yeah. What about replacing the estrogen? If genitourinary syndrome of lactation is causing this painful tissue thinning, what role does hormone replacement therapy or combined hormonal contraceptives play?
Well, the approach to estrogen replacement during lactation completely depends on the delivery mechanism.
Okay, break that down for me.
So systemic estrogen, meaning a pill or an absorbing patch that circulates through your entire bloodstream, especially synthetic forms like ethinyl estradiol, is highly problematic.
Why is it problematic?
The data indicates systemic estrogen can significantly drop a mother's milk supply, particularly if it's introduced before 6 weeks postpartum, when the supply is still calibrating.
Ah, because introducing systemic estrogen basically signals to the brain that the emergency is over, right? It reverses that biological seesaw fighting the prolactin.
Exactly. It tells the body to stop prioritizing milk. But we see a totally different outcome with local vaginal estrogen.
Local meaning it stays right where you put it.
Right. Using local treatments, like creams or pessaries formulated with estriol or estradiol, is overwhelmingly supported by the safety data.
And just to clarify for our listeners, a pessary in this context is a small, soluble block or ring inserted directly into the vagina to release the medication slowly.
Right. And the dosage in these local applications is remarkably low.
So it's not flooding the whole system.
Exactly. The hormone acts directly on the localized vaginal tissue to treat the thinning and severe dryness associated with GSL. Because it is applied topically to the affected area, practically none of it enters the maternal bloodstream.
Which means it doesn't enter the breast milk and it doesn't trick the brain's pituitary gland into dropping the milk supply.
Exactly. It acts purely as a local foreman for that specific construction site, leaving the rest of the city's triage plan completely intact.
That localized versus systemic distinction seems to be the absolute bedrock of postpartum medical care.
It really is the most important concept to grasp here.
Okay, here's where it gets really interesting. If systemic treatments are a risk to the nursing mother's milk supply, a lot of people naturally turn to topical med spa treatment.
Oh, absolutely. The desire for a postpartum glow-up is huge.
I mean, I get it, especially when you're sleep deprived and your skin elasticity has just tanked. But how does a med spa professional decide what is a safe surface polish versus a systemic risk?
The sources outline a definitive golden rule for aesthetic treatments while breastfeeding.
Let's hear it.
Mechanical intervention is generally safe. Chemical or systemic intervention is not.
Okay, mechanical is safe, chemical is not. Let's run through the safe list based on that rule.
Sure.
Hydrofacials are cleared. These use a patented vortex fusion device to push hyaluronic acid into the pores. And it's safe because the molecules don't enter the bloodstream.
Right, they just stay in the skin.
And dermaplaning is also greenlit. That's using a sterile surgical blade to scrape off dead skin cells and vellus hair. Completely mechanical.
Exactly.
And superficial chemical peels, utilizing very low concentrations of lactic or glycolic acid, are deemed safe because they simply don't penetrate deeply enough to be absorbed systemically.
Right, but the nuance applying to these treatments is fascinating, particularly when we look at the hugely popular procedure of microneedling.
Oh, using devices like the FDA-cleared skin pen.
Yes.
Wait, let me stop you there and push back on this, because if microneedling creates thousands of tiny puncture wounds in the skin, aren't we just giving the body more things to heal when it's already completely depleted of estrogen?
That is such a good question.
Right. I mean, why would the body respond well to intentional damage during GSL?
Well, this highlights a brilliant distinction between systemic healing and localized inflammation.
Okay. How so?
When those tiny needles puncture the epidermis, they create a highly targeted microinjury. The body doesn't need to mount a massive, energy-draining systemic response like it does for a pelvic floor repair.
It's just a tiny scratch, essentially.
Exactly. Instead, it triggers localized fibroblasts, which are the cells responsible for making collagen, to rush to that specific millimeter of tissue.
Oh, I see.
It forces a tiny, manageable repair response that the body can easily handle, even in a low estrogen state.
So the mechanical action of the needles is completely safe. But reading the clinic protocols, the catch for breastfeeding mothers is actually the pain management.
Yes, this is the big caveat.
Because standard microneedling almost always involves sitting with a thick layer of topical numbing cream on your face for like 30 minutes beforehand.
And the active ingredients in those numbing creams, primarily lidocaine, are designed to penetrate.
Right. They go deep.
They can be absorbed through the skin barrier, enter the maternal bloodstream, and theoretically cross into the breast milk.
Oh, wow.
Therefore, the strict protocol for a lactating mother who wants microneedling is that it must be performed entirely without the topical numbing agent.
Ouch. That requires a serious pain tolerance, just needles straight to the face.
Yeah, it really does.
But it perfectly highlights how rigid the boundary is between a mechanical action and a chemical one.
It does. And speaking of rigid boundaries, the medical guidelines provide a very clear do not touch list for med spas.
Let's go over those.
Injectables, including Botox and dermal fillers, are strictly avoided. Lipolysis, which involves fat-dissolving injections, and any topical or oral treatments involving vitamin A or retinoids are completely off the table.
Because every single one of those introduces active chemical substances into the body, and we simply lack the safety data for lactating women.
Right, we just don't know for sure.
The theoretical risk of those compounds crossing into breast milk is just far too high to justify an elective cosmetic procedure.
It's a risk-to-benefit ratio, where the potential risk to infant development massively outweighs the cosmetic benefit to the mother.
Makes total sense. So, what does this all mean for deep internal healing? We've covered surface treatments for the face and the skin, but childbirth obviously causes profound structural changes, particularly vaginal laxity.
Yeah, it really does.
This brings us to what is undeniably the most debated area of postpartum recovery in our stack of sources: internal energy-based devices.
Right. We are looking at clinical data for devices utilizing quantum radiofrequency, fractional CO2 lasers, and ERYAG lasers, and these are all applied internally to the vaginal canal.
Just to make sure the mechanics are crystal clear for everyone, these lasers and radiofrequency devices essentially cause a controlled microburn inside the vaginal tissue.
Correct.
The goal is to trick the body into rushing new collagen to the scene, right? It sounds incredibly similar to the microneedling concept on the face, but utilizing thermal heat energy deep inside the body.
That is precisely the theoretical mechanism of action. These devices aim to treat vaginal laxity, severe internal dryness, and mild stress urinary incontinence by inducing thermal trauma.
To force the fragile tissue to remodel its collagen architecture.
Exactly. But this raises a very important question. Just because we can induce thermal injury to stimulate collagen doesn't mean we should.
And the data in our sources is fiercely divided on this. And I want to be really clear to you, the listener, right now. We aren't endorsing either the cosmetic clinics or the medical bodies here.
No, we are just looking at the data impartially.
Exactly. We're simply unpacking the arguments both sides are making in the literature. On one side, aesthetic and cosmetic gynecological clinics report exceptionally high patient satisfaction.
They do. They point to women feeling more comfortable, experiencing improved lubrication, and regaining structural tone after radiofrequency or laser treatments.
But on the opposing side, major regulatory medical bodies, including the FDA, NICEAS over in the UK, and the International Continence Society, are urging extreme caution, particularly for postpartum women.
The clinical guidelines from these regulatory bodies highlight severe potential adverse events. They are documenting reports of vaginal burns, heavy scarring, and the development of rectovaginal fistulas.
Which is an abnormal and highly dangerous structural connection forming between the rectum and the vagina, right?
Yes, it's a very serious complication. They also cite cases of foreshortened vaginal canals, where the scar tissue contracts so much that it results in severe chronic pain during intercourse.
Okay, so if we tie this back to the very beginning of our discussion, the genitourinary syndrome of lactation, it becomes biologically clear why the risk profile might be elevated for a breastfeeding mother.
Exactly.
Because breastfeeding keeps estrogen levels artificially suppressed, so the vaginal tissues are already exceptionally thin, dry, and structurally compromised.
Right, they are already at a huge disadvantage.
So applying a thermal laser burn to tissue that is already biologically deprived of its primary healing hormone, our sideline construction hormone, is a massive gamble.
It's a huge gamble. The tissue simply might not have the cellular resources to heal the burn correctly.
So what do the guidelines actually suggest then?
The overarching consensus timeline for the medical guidelines is to practice patience. Experts strongly suggest waiting a minimum of 6 months postpartum.
6 months, okay.
But ideally, a mother should wait until breastfeeding has completely ended and normal ovulatory estrogen cycles have returned before even considering internal laser or radiofrequency interventions.
Okay, but if you're dealing with laxity or incontinence right now, and lasers are off the table for now, what does the evidence point to as a safe intervention?
Pelvic floor physical therapy remains the undisputed evidence-based first-line recommendation.
Because it physically strengthens the musculature without risking thermal damage to hormonally fragile tissues?
Exactly. It's a mechanical fix, not a chemical or thermal one.
Okay, let's pull all of this together. We started with a mission to understand how treatment while breastfeeding affects healing. And what the sources reveal is a massive biological compromise.
It really is a fascinating trade-off.
Lactation creates this unique, low estrogen environment that actively pauses maternal healing to prioritize the immense caloric demand of feeding the baby.
And navigating this requires incredible strategic precision. Local, non-systemic treatments are the proven safest bets.
Right. We're looking at targeted vaginal estrogen creams to combat structural dryness or mechanical exfoliation like dermaplaning for the skin.
Meanwhile, systemic interventions like oral estrogen that could suddenly tank your milk supply, or energy-based internal lasers applied to already fragile tissue carry very real documented risks.
It's all about respecting that biological triage until the city is actually ready to rebuild. But before we wrap up today, I want to leave you with a final, mind expanding thought pulled from the deep research on estrogen and wound healing.
Oh, the literature takes a truly fascinating pivot here regarding who actually benefits from estrogen therapy.
It really does, because we instinctively view estrogen as a strictly female or maternal hormone. Like we associate it entirely with pregnancy, periods, and menopause.
Right, that's the standard cultural view.
But the clinical sources reveal that estrogen deprivation is actually the primary cause of delayed wound healing in elderly men, too.
Which is just incredible to think about.
The cellular mechanisms for repair don't actually care about the gender of the patient, do they?
Not at all. They just need the right hormonal foreman on the job to direct the macrophages and build the blood vessels.
Researchers found that applying topical estrogen can rapidly reverse chronic, severe, non-healing wounds in aged men. And because it's applied locally to the wound, it does it without causing any systemic feminizing effect.
It's a hyper-targeted fix.
So if this works so universally, could this so-called pregnancy hormone eventually become the universal gold standard for treating severe physical trauma across all genders?
It's a very real possibility.
Right. If you have a severe burn or a non-healing ulcer, could a dose of local estrogen be the ultimate medical intervention? It's something for you to ponder long after this deep dive ends.
It completely shifts how we view the body's repair crews. Sometimes the cellular workers are all there, sitting in their trucks. They just need the right hormonal signal to finally start rebuilding the roads.
A perfect way to end it. Thanks for joining us on this deep dive.